Hello, I'm Dr. Jeffrey Hayes, Education Specialist of the American Society for Reproductive Medicine. Welcome to this presentation of the ASRM Grand Rounds webinar series. These webinars are designed to address topics in the ABOG Learning Guide in Reproductive Endocrinology and Infertility. Today's presentation is by Dr. Lisa B. Haddad. Dr. Haddad is an assistant professor in the Department of Gynecology and Obstetrics in the Division of Family Planning at Emory University School of Medicine. The title of her talk is Contraception for Women with Medical Conditions. I will now review the details of today's presentation. After the webinar is done, please do not forget to return to ASRM eLearn to take the post-test and complete the survey for your continuing education credits. You must complete the post-test questions successfully and complete the survey to receive credit and be able to print off your certificate. If you wish to ask a question to the speaker about this presentation, when you return to ASRM eLearn, click on the page link labeled Questions and an email address will be provided. The question period will be open for a number of weeks after this presentation is posted. After the time period for questions has expired, the questions page will be a frequently asked questions page pertaining to this presentation and topic. We are very excited for our talk today, so I will now turn things over to our speaker.
Thank you. Good morning. I'm going to spend the next hour talking to you about addressing the contraceptive needs of women with medical conditions. Recent studies have shown that despite the potential for serious maternal and fetal pregnancy-associated risks, contraceptive use is suboptimal among women with medical conditions. It's important to not overlook the contraceptive needs of these women and to provide them with appropriate counseling to avoid these risks and to choose the safest and most effective contraceptive methods they desire. My goal today is to provide you with tools to address the needs of these women. I have no disclosures. My learning objectives today are to review the effectiveness, risks, and benefits of different contraceptive methods, to review the United States medical eligibility criteria for contraceptive use, and to provide tips for the use of these guidelines to approach clinical cases of women with chronic medical conditions. I'll start by presenting a few examples of women where addressing their contraceptive needs may not be straightforward. This is a 41-year-old woman with a history of unexplained stroke who presents for contraception after a recent unplanned pregnancy. She was told in the past by her neurologist that she cannot use any contraception. This second case is of a 38-year-old woman who has had gestational hypertension with all of her prior pregnancies. Her blood pressure today was 170/94. She wants to have regular menses and desires contraception. This third case is a 25-year-old with an insulin-dependent diabetes who has been using depomedroxyprogesterone acetate for contraception for a year. She reports that her kidney function has been recently worsening, according to her doctor, and has questions about continuing with her contraceptive method. There's a 36-year-old woman who reports occasional migraines with aura and wants to continue her vaginal ring. She's come to you for her annual exam. It's important to know that not all birth control is created equally, and we shouldn't prevent all options as such. When thinking about method effectiveness, we must consider that typical use is not equivalent to perfect use. There's a hierarchy of effectiveness for contraceptive options. CDC has presented contraceptive options as 3 tiers here. The lowest, Tier 3 methods, have typical failure rates of 18 or more in 1 year. These are the male condoms, female condoms, withdrawal, spermicides, sponge, and fertility awareness methods. The second tier methods have pregnancy risks of 6 to 12 pregnancies per 100 women in a year. These methods, the injectable, the pill, the patch, the ring, and the diaphragm, are user-dependent methods that are commonly used. The Tier 1 methods, these are the most effective methods, are the reversible methods, the implant and IUD, and the irreversible methods, the permanent sterilization, both female and male sterilization. The LARC methods, the long-acting reversible contraceptive methods, have the highest effectiveness of the reversible methods. These methods have high satisfaction and continuation. They do not require any surgery or general anesthesia. Further, they're very cost-effective and importantly reversible for women who are unsure about their long-term family planning needs. These are easy to use, and we consider them you get it and you forget it, because you do not have to deal with user dependence. Thus, typical use is often equivalent to perfect use. These methods are over 20 times more effective than other non-LARC hormonal contraceptive options, even when controlling for demographic differences among users. The copper T380A IUD is currently on the market in the United States and approved for up to 10 years of use. The mechanisms of action include inhibition of sperm migration and viability, changes in ovum transport speed, damage to or destruction of the ovum, or all effects, and all of these effects occur before implantation. The copper T380A IUD has multiple benefits as well as risks. These benefits of the copper IUD include its high effectiveness, as mentioned. There have been several studies to show that efficacy continues to 12 years or longer with this method. Satisfaction rates of users are extremely high, above 90%, with high continuation rates in 1 year. And one benefit is that most users have regular menses with this method. Thus, it does not lead to the same irregularity or changes in menstrual cycle that many of the hormonal methods may lead to. Further, they have no hormones, so individuals that want to avoid hormonal methods or have contraindications to hormones may use these methods effectively. Risks of these methods include risks of pregnancy, which, as mentioned, are very low, changes in the menstrual cycle that may be including heavier menses and increased cramping. These are particularly important over the first 6 months of use. Increased risk of infection, and the risk of infection returns to baseline at about 20 days after initiation. So it's primarily in that initial phase, and particularly among people with current STIs. Risks of perforation, meaning the IUD goes through the uterus. Now, that risk is quite low, about 1 in 1,000. And risks of expulsion of the IUD, where the IUD is pushed out partially or entirely. There are also many secondary benefits of this method. The copper IUD is currently the most effective emergency contraceptive method that is out there. If placed within the first 5 days, it reduces the risk of pregnancy and is more than 99% effective. Other benefits of the copper IUD include reduced endometrial cancer risk. There are currently 4 Levonorgestrel IUDs on the market, a 13.5 milligram, 19.5 milligram, and 2 52 milligrams IUDs. The initial release rate will vary between 14 and 20 micrograms per day, will decrease with time with use. These IUDs are approved for up to 3 to 5 years, depending on which one, with the 52 milligram IUD showing excellent efficacy up to 7 years of use. And the mechanisms of action include endometrial suppression, thickening of the cervical mucus, inhibition of sperm, and all of these methods occur before implantation of an embryo. The Levonorgestrel IUD have multiple benefits, including the efficacy of contraception. As noted, these methods have a failure rate of less than 1 in 100 per year. There's high satisfaction and continuation, and individuals tend to have lighter menses with few side effects. The risk of perforation is less than 1%, and the risk of infection is similar to the copper IUD. Risk of infection similarly is highest within the first 20 days after insertion, and some studies suggest that the risks of infection may actually decrease with use of these methods. Risks of irregular menses are very common with this method, and the risk of pregnancy, as mentioned, is quite low. Other secondary benefits include specifically treatment for heavy menstrual bleeding or anemia. Within the first 3 months of use, there's an 82% reduction in menstrual bleeding on average, and by 12 months, 90% reduction. About 20% of individuals will be amenorrheic within 12 months of use, and 60% will be after 5 years of use. With fibroids, studies have shown that you have a decreased menstrual blood loss of 84 to 90%, with an increase in hemoglobin, particularly for those who are anemic. Other benefits include improvement of dysmenorrhea or pelvic pain, and for treatment of endometrial hyperplasia. The Etonogestrel Implant is the third option for the long-acting reversible contraceptives. The current available Etonogestrel implant on the market is approved for up to 3 years. Mechanisms of action include suppression of ovulation, thickening of cervical mucus, and endometrial atrophy. These effects all occur before implantation. Benefits of the Etonogestrel implant include its high efficacy, Its true effect has been shown to be up to 4 to 5 years after placement, so 1 to 2 years beyond what is currently approved. High satisfaction and continuation rates, lighter menses, and the low prevalence of side effects with these methods. The potential risks include low risks of pregnancy, prolonged menses, so individuals with this method may have a lot of irregular bleeding and extended bleeding. Although overall bleeding may be lower, it can be quite bothersome, and many individuals will discontinue the method because of irregular bleeding. The risk of infection or issues around the insertion site is very low, and hormonal side effects may occur with this method. Secondary benefits may include improvement of dysmenorrhea. The second-tier methods are often the methods that are more familiar to our patients. These are the methods that are tried and true. There's an enormous amount of data on these methods, and many individuals trust them. And when they think of birth control, they often think of these second-tier methods. These are the pills and the injections, as well as the patch and the ring. Considered as part of the second-tier methods are also the diaphragm, although the diaphragm is rarely used and more challenging to obtain. Secondary benefits of these methods include menstrual regularity, particularly for the combined hormonal contraceptive options. Regular menstrual bleeding is something that many of our patients will desire, and thus some of these methods are beneficial for that. Heavy menstrual bleeding can improve with the use of the hormonal second-tier methods, and they're important for individuals with bleeding disorders as well. For the combined hormonal contraceptive methods, acne can also significantly improve and is often used as a treatment for cystic acne, particularly among the adolescent women. Dysmenorrhea and endometriosis or other pelvic pain disorders can also be, the symptoms can also improve with the use of the second-tier hormonal methods. For individuals with PCOS, combined hormonal contraceptive methods may reduce the hyperandrogenic symptoms associated with the syndrome. For individuals with menstrual migraines, the use of these second-tier methods may also reduce the incidence of these headaches. Further, second-tier methods have been approved for the treatment of premenstrual dysphoric disorder, and further, there is some evidence to show that among users of these second-tier methods, there may be a reduction in ovarian, endometrial, and colon cancer. So the combined hormonal contraceptive methods contain both estrogen and progesterone. The estrogenic component inhibits FSH and LH and subsequently inhibits ovulation. The progesterone component can thicken the cervical mucus to prevent sperm and also inhibits capacitation of the sperm. So the discovery in 1938 that the addition of the ethinyl group to the estradiol resulted in both an orally active estrogen compound and a dramatic increase in the estrogenic potency was a major advance in steroid biochemistry. This compound, known as ethinyl estradiol, is the estrogen in nearly all contraceptives currently used. Mestranol is a prodrug converted to ethinyl estradiol, which is available in some combined methods. Although initially dosing of 50 micrograms or higher were used in the early combined pills, it was found that there were greater side effects with these higher estrogen doses, and lower doses could be better tolerated with the same benefits that in terms of birth control efficacy. These 30 lower dose options can be thought of as the low dose, which are 30 to 35 micrograms, and the ultra low dose, which is 20 micrograms or lower. For the low dose methods, these are important to maintain bone density, and the higher estrogen dose can often help with reducing some of the irregular bleeding that you may have with the lower ultra low doses of combined hormonal contraceptive. For the ultra low doses, you may have fewer estrogenic side effects, but as mentioned, may have more breakthrough bleeding, and many individuals may have more difficulty with these methods, and there may be higher discontinuation. Currently available combined oral contraceptives contain variable dosages of different progestins, and these doses vary on the potency of these different progestins. There are several different types of progestins used in combined hormonal contraceptives, and they can be classified by pharmacology and generation. There are C21 progestins, which lead to the pregnanes, the 19-nortestosterones, which lead to the estranes and the gonanes, and then the spironolactone derivatives, which primarily is drospirenone, based on the differences in the pharmacology and receptor affinity of these different progestins. Different methods may have differences in degrees of estrogenicity, androgenicity, and progestogenic effects, as well as differences in mineralocorticoid or antimineralocorticoid activity and glucocorticoid activity. Overall, there is increased potency and half-lives from the first to the third generation. Older, more androgenic progestins may block effects of exogenous estrogen. Newer progestins may allow for more expression of the estrogenic effects. This table here shows the variable degrees of estrogenic, progestogenic, and androgenic activity of the different generations, as well as some variability even within generation of some of these effects. Notably, the drospirenone has high antimineralocorticoid activity and tends to be much less androgenic than the other methods. In addition to these differences in estrogen and progestin formulations, there's also differences in how the pills particularly are formulated. The monophasic pills contain the same amount of estrogen and progestin in all of the active pills in a pack. Because of the uniform hormone level in all the pills, monophasics are the least likely to cause side effects such as mood changes that can result from fluctuating hormone levels in the body. Biphasic and triphasic pills contain different dosages of progestins or estrogens throughout the pill pack. Compared with monophasics, these pills reduce the total hormone dosage a woman receives and are thought to better match the body's natural menstrual cycle. Biphasic pills change the hormone level once during the menstrual cycle. Triphasic pills contain 3 different doses of hormones in the active pills, changing every 7 days during the first 3 weeks. 4-phasic pills contain 4 different doses of hormones in the active pills. The first 4-phasic pill was approved in September 2010. Other derivations of combined hormonal contraceptives include shortened pill-free intervals, extended use, and continuous use. Notably, hormonal contraceptive formulations may be packaged with the shorter pill-free intervals as well as for extended and continuous use. However, many of the monophasic pills can be used in the same way by skipping the pill-free interval in the pill pack. Now turning to women with medical conditions and how to approach these women. These are women with risks that can increase with pregnancy and also may have increased risks with certain contraceptives. Further, these women who have multiple medications, doctor visits, and/or out-of-pocket expenses may not be compliant with the use of contraception. These women are at greater risk for unintended pregnancy with greater consequences of those pregnancies. Notably, the alternatives to a contraceptive method is often pregnancy, and depending on if you use a calendar method, withdrawal, or no method at all, the risk of pregnancy at 1 year can be 15 to 85%. Thus, our clinical dilemma for these women is the balancing of contraception and pregnancy risks. Overall, in most cases, pregnancy will be riskier than contraceptives, but in many cases, alternative contraceptive options may be better than one method. Thus, we must consider the broad range of contraceptive options in our counseling. We now have a great tool to aid us in treating women with chronic medical conditions. The Centers of Disease Control and Prevention, CDC, has come out with the U.S. medical eligibility criteria for contraceptive use. The most recent version, published in 2016, is available online and is very helpful because it provides an excellent guide for balancing the risks of a contraceptive method with different medical conditions and allows us to classify these risks based on a 4-point scale. It allows us to make educated, individualized decisions regarding complicated patients, and it's meant as a clinical practical tool. Systematic reviews weigh all the evidence from studies in the medical literature, are peer-reviewed, and if no evidence is available, there may be information that is based on theoretical risk or expert opinion that's incorporated into the eligibility criteria. These guidelines are adapted from the WHO medical eligibility criteria into a U.S. context by adding some conditions that are relevant to the U.S., considering the evidence in the context of U.S. conditions, methods, and standards of practice. Some methods we do not have that may be available globally, such as combined injectables and levonorgestrel implants, are not included. Further, unmeasured blood pressure is not a category in the U.S. where it may be globally, thus not included in the U.S. medical eligibility criteria. In thinking about contraceptive use, they have also developed a list of conditions where they have increased risks associated with unintended pregnancy. This includes breast cancer, diabetes with nephropathy, retinopathy, or neuropathy, or greater than 20 years of duration, severe hypertension, which is defined as a systolic blood pressure of greater than 160, or diastolic blood pressure of greater than 100, bariatric surgery within the last 2 years, stroke, poorly controlled HIV, sickle cell disease, and cirrhosis. Although not a hard and fast rules when clinical judgment is limited, the categories can be simplified into rules and into yes-no categories. Overall, category 1 and 2 are yes, and 3 and 4 are no. Some common themes in that MEC are that overall IUDs and implants are typically the safest options. It is important to avoid, though, the complications that occur at the time of placement. Other progestin-only options and non-hormonal methods are generally safe options, however, may have reduced efficacy. And then for the estrogen-containing methods, these can increase risk of cardiovascular complications in women with risk factors. In practice, the MEC may be helpful in your ability to effectively counsel patients about their options, both considering the risks of pregnancy and the risks of the different methods, as well as offering alternatives to these patients. They also can be helpful in your documentation and to communicate your recommendations with other providers. For conditions not in the MEC, it is often because there's little evidence about the safety of these methods. In these cases, you can review the possible complications of this condition and some common themes for the use of methods. You also may decide to review the literature, including systematic reviews or anything in up-to-date, as well as if you still are feeling unsure of what your recommendations would be, you may want to consult with an experienced clinician who deals primarily with complex contraception. In addition to the MEC, it is often helpful to refer to the U.S. Selected Practice Recommendations, also developed by CDC. The U.S. SPR provides guidance both within the document and summarized in a user-friendly chart to help guide providers on how to counsel patients on backup needs of all methods. These are evidence-based guidelines for providers on what tests are required before initiation of contraception, when to initiate or change methods, how to manage side effects and non-adherence, and how to initiate a new method after using emergency contraceptive, for example. Examples of information in the U.S. SPR include this detailed chart on how to start specific contraceptive methods. As you can see, all methods of contraception can be started at any time if the provider is reasonably certain a woman is not pregnant. To ensure that she's not pregnant, once the method is started, she should use an appropriate backup method for a recommended period of time to prevent a new unintended pregnancy. This chart is available in the SPR for your reference. The U.S. SPR provides highly accurate criteria that a provider can review with a patient to be reasonably certain the patient is not pregnant prior to initiating contraception. These can be used without a pregnancy test. If a woman has no signs or symptoms of pregnancy and meets any one of the SPR criteria listed here, the provider can be reasonably certain that she is not pregnant and quick start contraception. The U.S. SPR provides recommendations that addresses exams and tests needed prior to starting a woman on a method. Down the left side, you can see some potential exams and tests. Across the tops are various contraceptive methods. These recommendations are characterized into 3 classes. Class A are essential and mandatory for a given method, and Class C does not contribute substantially to safe and effective use of the method. The only A-level recommendations, meaning essential and mandatory, are a blood pressure measurement prior to initiation of combined hormonal contraceptives, and a bimanual exam and cervical inspection prior to initiation of an IUD or diaphragm. Idea here is to limit the required exams and tests to those that are needed to ensure the method is safe. The recommendations for a blood pressure measurement comes from a systematic review which is compared to those women who did not have their blood pressure checked. No evidence was identified for other hormonal methods and blood pressure measurements. Pelvic examination, Class C, is not necessary before initiation for combined hormonal contraception because it does not facilitate detection of conditions for which combined hormonal contraceptions would be unsafe. This chart from the US SPR shows management algorithms for bleeding irregularities. For example, if she does not have an underlying gynecologic problem and wants treatment for irregular bleeding with an implant, she can consider NSAIDs for 7 days, or hormonal treatment if medically eligible with a low-dose combined hormonal contraceptive or estrogen for a short period of time of 10 to 20 days. If bleeding persists and she finds it unacceptable, she can be counseled and offered an alternative contraceptive. The updated CDC Contraceptive app for the Apple and Android smartphones and tablets now include both the MEC and SPR in a user-friendly format with easy navigation between two sets of guidance. It also easily links to other CDC guidance, such as STD treatment guidelines. This updated app is available for download through our website. Many providers who use smartphones for other clinical references find this to be the easiest way to access the guidelines in everyday practice. So, returning to our clinical cases. This is our 41-year-old with a history of a stroke who was told that she cannot use contraceptive by her neurologist. What we know is that the risk of myocardial infarction is increased with combined hormonal contraception, and the risk may be doubled. This is not increased for individuals who previously used combined hormonal contraception and discontinued it. And although this risk is increased, the actual risk of myocardial infarction is actually quite rare, with a 1 to 2 per 10,000 reproductive age women. For this woman with a history, the doubling of risk with combined hormonal contraceptives is unacceptable, especially considering the severity of the outcome if she develops another CVA. That said, there are many other options that are acceptable for her. IUDs, for example, are safe for use. For progestin-only pills and implants, these can be initiated. However, continuation in the setting of a CVA is not recommended, or if she has additional risk factors for a CVA, it may be something that you may not consider. You may not want to start these methods. Notably, we must remember that it is a condition associated with a greater adverse outcome associated with pregnancy. Thus, avoiding unintended pregnancy is critical. Similar to arterial events, slightly more common are the venous thromboemboli. A risk factor for thrombosis can now be identified in over 80% of patients with venous thrombosis. Virchow's triad considers 3 factors associated with venous thromboembolism: stasis, endothelial damage, and hypercoagulability. While estrogen is one risk factor due to its increase in a prothrombotic state, there are several other factors, such as obesity, trauma, surgery, cancer, and inherited thrombophilias. Further, there is often more than one factor at play in a given patient. Accordingly, many patients with VTE fulfill most or all of Virchow's triad of stasis, endothelial damage, and hypercoagulability. When counseling, we must consider the relative risks of VTE for each woman. For example, for normal reproductive aged women, the risk of VTE is about 4 to 5 per 10,000 women years. For those women using the typical sub-50 microgram combined oral contraceptive pill, that risk increases to 8 to 10 per 10,000 women years. For pregnant women, notably, that risk is 29 per 10,000 women years, and for women in the immediate postpartum period, that risk increases to 300 per 10,000 women years. Many of these risks are also increased by modifiable risk factors such as obesity and smoking. For example, for women who are obese, the risk is 2.3 times that risk for women compared to women who have a normal body mass index of under 40. For example, for women who are obese, your risk increases by 2.3 times the risk compared to non-obese women. And then further, for women who have greater than 40 BMI, that risk increases to 2.7. Similarly, for smoking, if you smoke more than 20 pack years, your risk is 4.3 times that risk compared to women who do not smoke. So these modifiable risk factors are things that you need to consider when you are counseling a woman on the use of combined oral contraceptives, and often that risk may increase to the level where it may not be an acceptable option for these women. Importantly also is that for women who are currently using combined oral contraceptives, The risk of thrombosis typically increases during the first 4 months after initiation of therapy. And after the first 4 months, that risk tends to not increase more based on duration of use. So the risk decreases to previous levels within 3 months of cessation further. So when considering the risk of VTE, we must acknowledge that pregnancy alone increases the risk of clotting. Personal history of VTE further increases the risk during pregnancy, and that additional risk factors may increase these risks. In addition, anticoagulants may modify this risk-benefit ratio. So for individuals who are on anticoagulants, combined hormonal contraceptives may not have as great of a risk for those that are not on anticoagulants. Per the CDC medical eligibility criteria, combined hormonal contraception is restricted for use for those who are high risk of a repeat DVT or PE, as well as those with prolonged immobilization. For those who are lower risk, it is considered a 3, where overall the risks outweigh the benefits. However, there may be certain conditions where the benefits may outweigh the risk for those individuals on a case-to-case basis, such as individuals with severe menorrhagia or hemorrhagic cysts. Individuals with minor surgery without immobilization have no restrictions with combined hormonal contraceptive use. However, other than the combined hormonal contraceptives, for individuals with high risk for DVT or PE, there are no restrictions for use. For our second case, a 38-year-old woman with gestational hypertension in all of her prior pregnancies, who's currently hypertensive, who wants to have regular cycles. So for her, she has increased risks of pregnancy. She also may, in the case of some women with hypertension, be on antihypertensives that may be contraindicated in pregnancy. For combined hormonal contraception, that method may actually increase the blood pressure in some individuals, while for most individuals this increase is quite modest, about 8 milligrams of hemoglobin systolic or 6 diastolic. This may be significant for people who are already hypertensive. And per one case-controlled study, for individuals with a history of hypertension, there was an increase in CVA for those individuals with combined oral contraceptive use. So for women who have poorly controlled hypertension or vascular disease, combined hormonal contraception is contraindicated. For these individuals, additionally, one should avoid the use of injections. For individuals with controlled blood pressure hypertension and those with elevated pressures that are just mildly elevated, those are considered a category 3, where overall the risks outweigh the benefits. Notably, most of the other contraceptive methods are safe for use for these women. For our patient here who desires to have regular cycles, the option that may be the best one for her may be the copper IUD, because the combined hormonal contraceptive options are not ideal, and most of the other progestin-only methods will lead to irregular bleeding. In this case, the 25-year-old with insulin-dependent diabetes on depomedroxyprogesterone acetate with worsening kidney function. What are her contraceptive options and things that we need to consider? For women with diabetes, they are at increased risks during pregnancy, both for themselves as well as worse fetal outcomes. There is very little data to suggest that contraceptive methods alter glucose metabolism or insulin requirements. Overall, in non-diabetic women, these changes, if any, are insignificant. For obese or diabetic women, there may be minor effects of contraception on glucose metabolism and insulin requirements. That said, there's increased risks of VTE and vascular events for women who have severe diabetes with nephropathy, retinopathy, or neuropathy, or other vascular diseases, or those who have long duration of diabetes. For these women, combined hormonal contraception should be avoided. However, in other conditions, they can be used, as well as most other contraception is safe for use, so the progestin-only methods and the IUDs. Our last case is a 36-year-old with migraines with aura, who's been using a continuous use of the vaginal ring. So migraines are extremely common in the United States. The incidence of migraines are about 18% of women in the US, with a cumulative lifetime prevalence of about 43% among women, with the peak prevalence in the 20s to 30s, the peak reproductive years. Migraines can be classified as migraines without aura based on their menstrual or non-menstrual association, as well as migraines with aura. So in terms of risk of stroke, we know migraines may increase the risk of an ischemic stroke. We know combined oral contraceptives or combined hormonal contraceptives can increase the risk of ischemic stroke. So what about the combination of the two? What do we know about that? And is it additive, or do they lead to an even greater risk in combination? So migraines and hormonal contraception combined can increase risk. However, there's limited evidence by the specific migraine subtype. So for those with aura, we believe that risk is increased even greater. However, in cases without aura, the evidence is quite mixed. And if there is any increased risk, the risk is quite small. With people with a remote history of migraines, there is no evidence on whether risk continues. For hormonal contraception, we know that combined hormonal contraception in itself increases risk, even the low-dose estrogen estradiol pills. For progestin-only contraception, there is no evidence of increased risks. So along with this evidence for combined hormonal contraception, those with aura, it is contraindicated. However, with those without aura, it's considered a category 2, with specific recommendations that any individuals with additional risk factors such as age, hypertension, and smoking may be considered for having an increased risk with these methods, and alternatives should be suggested. So in summary, contraception is generally safer than pregnancy for women with chronic medical conditions. It's important to know that you don't need to know every chronic medical condition in order to care for these patients. There's evidence-based resources available that can assist you, and these are easy to use and access. So the CDC medical eligibility criteria and the selected practice recommendations are easily accessible and should be used on a regular basis. In general, most women are eligible for at least one effective method, with many women eligible for multiple methods. In your counseling, you should counsel on all the risks and benefits of any contraceptive method that the woman is eligible for, in the context of also discussing the important differences in efficacy of these methods. And your goal is to avoid any additional risk with a contraceptive method if possible, while still caring for a patient and addressing your counseling toward their specific needs. Right here is the link to the CDC website for the contraceptive guideline for healthcare providers, where you can find both the SPR and the MEC. And I welcome any questions. Thank you for your time.